creating community-driven integrated care, what it looks like to put primary health care as the foundation of a neighborhood health system with Jen Quinlan, CEO of Flemingdon Health Centre in Toronto. Jen is a dynamic health system leader with over 20 years of experience in both local and global contexts. She's passionate about enhancing community health and well-being through community-driven integrated care. For the past decade, Jen has led Flemingdon Health Centre's evolution into a leading provider of integrated primary health care in Ontario. Under her leadership, innovative programs have flourished, including Health Access Thorncliffe Park, the Thorncliffe Park Community Hub, the East Effort Community Health Ambassador Program, and expansion of interprofessional primary care teams as part of the Primary Care Action Plan investments. In 2025, Jen was awarded the King Charles III Coronation Medal for her exceptional community service. After Jen's presentation, we'll explore where redundancy persists in our neighborhood systems simply because we've always funded it that way, and what it takes to redesign community at the community level. So welcome, Jen.
Perfect. Good morning. Hi, everyone. Thanks so much for that lovely introduction. I'm really honored to be here today and to see so many familiar faces. After a wonderful day yesterday, I thought that it would be just a great opportunity to build on some of the ideas, but also, as Melissa said, shift slightly in terms of philosophy, in terms of approach, to ground us in community. So really looking forward to that. So today I'm going to focus on how we as leaders can create community-driven integrated care initiatives to solve our most entrenched health system issues. Because I believe by championing community-driven integrated care, we could significantly transform health outcomes in Canada. My reflections from day one, learned a lot, loved all the speakers, really came away with some fresh perspectives. But I did get the sense that we were sort of reinforcing a philosophy that we're also trying to challenge. So I got the sense that we were thinking about how to put hospital in the home, or how to put some of our services that are primarily acute driven into community. And I would argue that perhaps we want to think about that in a flipped kind of way. We criticized that only 4% of investments are in home care, but yet we're talking about putting hospital in home rather than enhancing true home care. So these are some of the things I'd love us to chat about today, and some of my reflections from yesterday. And I say it all from a very loving place to my acute care partners. So I think we're in that space, right? After our dinner last night, we're able to have we're safe space. Yeah, perfect. Okay, so for those who don't know, this is Flemingdon Health Centre. I have the privilege of leading an amazing organization. We're a multi-service organization that provides team-based primary health care, community support services, and community mental health supports for a community of newcomers in some of Toronto's most diverse and low-income communities. It's a privilege to serve over 30,000 residents in the neighborhoods, and I'm really grateful for the opportunity to lead the work. This is me. I'm the CEO of Flemingdon Health Centre. We just wrapped up, actually we're just in the process of the last month of our 50th anniversary. So it's been a great year of celebration. Thank you, yeah. Community health centres in Ontario are, I think, about 55 or 56 years old, somewhere around there. So we're one of the first, not quite the first. I also, just from a personal perspective, I was actually born about 1 kilometre from here. It's now a YMCA, but it was in fact a hospital some decades back. And I'm honoured to be back in the Bow Valley where I'm coming home. Okay, so for today, I want us to explore what I think is the meaning of integrated care, to understand the elements of creating an integrated care program, and how we as leaders would work differently when leading an integrated care initiative. So I led with a statement that community-driven integrated care can solve some of our most entrenched health system issues. And from my perspective, and I think some of this was shared yesterday, it's pretty bleak right now in terms of the situation that we're in community. So in Ontario, over 2.5 million people don't have a family doctor. We talked about how that's pretty consistent across the country. Investments in primary care have been minimal, despite the constant reassurance that primary care is at the foundation of the health system, right? So we're told that regularly. I don't know if we feel that on the ground necessarily. Frontline staff and leaders are leaving our field, I would say even at greater rates than in the acute and some of the other parts of the health system, or they're significantly changing their job expectations. A lot more expectation from clinicians to move to part-time, sometimes even just relief work, really moving away from that longitudinal, ongoing primary care. We know that inflation is eating away at both our individual, our clients' budgets, but as well as our organizational budgets. So a flat budget is no longer something that is sustainable because year over year, you're struggling to make ends meet. Cuts to social service are also making people sicker. So our communities are actually having harder access to food, to employment, to things that would generally be something that could help enhance their health. And unfortunately, the economy is continuing to worsen. So it's not like lots and lots of money is coming our way in order for us to solve these entrenched issues. So with that bleak picture, I thought, what can we do to create the momentum to change this? Over the past 10 years, Flemingdon Health Centre has been changing our service model to one of community-driven integrated care. And we've actually leaned on 3 frameworks to build out this model. And this is where I really would say, from a philosophy perspective, this might feel a bit of a discomfort, right? This is not, I would say these 3 frameworks are not typical healthcare frameworks. I don't have Lean Six Sigma up there. I don't have some of those pieces, although I will reference the 5 Whys later. But these are ones where I really feel if we're able to work in new, interesting ways through these 3 frameworks, which I will walk through, I think we can really make some significant change. So the first is complexity theory, the second is integrated care frameworks, and the third, and probably the one that might challenge folks the most, would be our social justice framework. So by grounding our approach in these 3 frameworks, we're taking the best practices from a number of fields not typically used in community health to create a new way of working. Before we go any further, I want to pause and acknowledge how significant this shift has been for our organization. Healthcare and its silos have been created for a reason. We aren't good at working differently, and we certainly aren't good at true innovation. We like to tinker around the edges and congratulate ourselves, myself included. And frankly, there's a lot of people who are disenfranchised with healthcare because of that. Our current innovation motto in primary care is still "axe the facts." It's hard to take us seriously in 2025. This is one of my favorite quotes that guides our work. When we hire new leaders into Flemingdon Health Centre, I now share a confidential briefing note. So when you are, if anyone is interested in working at Flemingdon Health Centre, if you're one of the top 2 or 3 candidates, you get a note that says why you should not work at Flemingdon Health Centre. And it is scathing. It is intense. It's very cathartic for me to write. And I describe the messiness of our model. I talk about the lack of autonomy in decision-making because of how much partnership we do. I talk about both the frantic and the slow pace of our work and the incredible need in the community. It's high stakes and hard, and if people are turned off by that note, it's better we just kind of part ways at that time, respectfully enjoy each other's company, and move on. So if you think competition is hard, you should try collaboration. I know we had a lot of team sports things yesterday. I'm a big basketball fan, so sometimes this quote has Caitlin Clark beside it. I do think if you are someone who's interested in this type of work, looking at the King's Fund, looking at IFIC, the International Foundation on Integrated Care, there's a lot of great resources about how truly hard collaboration is and trying to get it right. So here's another thing I just wanted to clarify. When we talk about integration, we're talking about integrated care. And so there was a time in Ontario where it was a really big push for integration. There was something called the Local Health Integration Network. A lot of organizations ended up merging. And so I just want to differentiate that that's not the type of integrated care that I'm referring to. So our model talks a little bit more about a connected pathway with joint accountability for success rather than the formal merging of legal entities. There was a metaphor about cooking yesterday. I'm going to have a home renovation metaphor. So we see mergers like a home renovation. You start out with such strong energy and great ideas and best intentions and a budget. You then come against many different obstacles, and you're quickly faced with a stark reality check. You end up making compromises. You feel defeated, and you really just want the whole thing over. I don't know, has anyone renovated their house and had that experience? Yeah, you really just want that thing over. So to me, I've been a board member, I've been a staff, I've been a leader in a number of mergers. Best of luck to the people who are bold enough to do that. It's very impressive and hard work, but I'm not sure it's actually leading to the goals that people are setting out. So I see our energies used differently in an integrated care pathway. And I see integrated care like throwing a party with your closest friends. You don't really care about the house or your decor. Everyone brings their best dishes to contribute, and everyone cleans up together. Yes, you're probably getting on each other's nerves, and you're definitely gossiping about your family and friends in the kitchen, but you have a love and commitment to keep supporting each other and to have another party soon. I know we talked about some thought leaders yesterday. Who's read Getting to Maybe? Yeah. This is one of my favorite complexity books and my favorite complexity thought leaders, Frances Wesley and Brenda Zimmerman, Canadian thought leaders out of, I think, Waterloo, possibly. So for me, when I'm talking about integrated care, this is our first theory that we're using, complexity theory. And so when we're looking in the community, thinking about a massive change or a new way of working, how do we plan for it? What are the skills needed to lead? So Flemingdon turned to Frances Wesley and Brenda Zimmerman and the book Getting to Maybe. We have a leadership book club at Flemingdon. I don't know if anyone else does that. So once a year, we all read the same book, and then we kind of, chat about it. This was one of our early book club books. Frances wants us to see leadership in complexity. In this room, we're all leading some kind of change, whether it be a program or a service, a department, an organization, or a movement. And often we're taught that when you have a big, scary project in front of you, you should break it down into smaller parts. You should use project management principles, create a project charter, have terms of reference for committees. You should create structures that drive change. But what does all of that planning actually lead us to? Does it actually drive change, or is it something more administrative that emerges? And Frances and Brenda would argue that, in fact, all of that is not a good use of our time. The first time I heard Frances's ideas about leading in complexity, I wasn't sure it was for me. She's very confident in her sort of messiness. She talks about riding energy flows. And to me, I was like, what on earth? As a leader, if I walked up to my board and said, well, I'm really looking at the energy flows in the room, and I'm not really sure I'm riding them properly. I don't really think I would be taken very seriously. But I realized my discomfort was because I needed to challenge my own skills. I needed to be better at leading in the moment, at reading the room, and at motivating others. Leading in complexity is, Frances calls it, about system acupuncture. And I love that term. I love the term system acupuncture. She talks about putting pressure at the exact right spot in order to create a ripple effect. But she says you can't actually find a blueprint for success because things are always changing. So as Frances says, leading in an environment like this is an emergent process. So you have to be comfortable with that discomfort. And creating the environment for integrated care is about describing the local complexity, the interconnectedness, and the challenge of the health and social care sectors. So maybe complexity for you is rurality. We talked a little bit about that yesterday in Eastern Canada. Complexity at Flemingdon is caring for newcomer communities, caring for new waves of refugees and folks who don't speak the same language and have different socioeconomic status issues. You may also have mental health or addiction needs in your community, or you may have all three. And so Francis would say that no matter what you're shaping in complexity, you need to get better at sort of feeling and using the moment to make change. Very different than lean, and I'm green belted. I'm not wearing my green belt, but I have one somewhere. So then we get to seizing momentum. What if we're misreading our problems? What if we're kind of, still working on figuring out how to read the room? How we identify the symptoms of problems and the root causes. Here's another thought leader here, which I'll talk a little bit more about. So when we're talking about integrated care, we really want to solve the root cause, not just the symptoms of the problem. And this is where I'll go back to my green belt. So of course, Toyota's famous 5 whys, I want to just pause quickly and do a little primary care 5 whys. So an example is we're in a primary care crisis. So typically you would ask why? Because we don't have enough family doctors. Why? Because medical learners aren't choosing family medicine. Why? Because the health system is not set up to reward longitudinal, high-quality primary care. That's 3 whys. Now, why? Because we have not invested in primary care organizations and teams. And lastly, why? Because the system sees primary care organizations as disconnected and lacking cohesion. And so it keeps us out of this idea that if you invest in primary care, you're investing in the system. And I would say that's one of our biggest challenges as primary care and community organizations is funders, governments, et cetera, don't have the trust that if they invest in us, that we're actually going to create a system change. And that is something that I think we collectively should challenge and work together on. That would be one of my hopes out of this conversation. Primary care is not trusted to make the big system changes that are needed. Funders would rather go to known entities like acute spaces instead of taking risks on investing in primary and community care. So how would we change that? How would we get folks, organizations more trusted, and how would we as leaders become more trusted? How do you build trust? So I really love Frey and Morris's work. Are people familiar with them? Another opportunity. I have another book that they have in the next slide. But they're really great thought leaders, and they break down trust into something that I think is so helpful, and we talk about this a lot in our partnerships. So we talk about how trust is the combination of logic, authenticity, and empathy. And so as leaders, we can really ground ourselves in logic. We're all very trained. We're all very, sort of used to the work that we're doing. We're hopefully quite logical. I think the other 2 are areas where we want to sort of work and challenge ourselves. One around being authentic. Coming across as an authentic leader is an ongoing work and challenge, right? Being the right level of vulnerable, being the right level of competent, all of that. But the last one is about empathy. And Frey and Morris say that that's the one we actually, as leaders, should pay the most attention to. That if you are in a low empathy environment, it doesn't matter if you're logical and authentic. It's really about creating that connection. And so Frey and Morris put a show, don't tell mantra forward to us as an opportunity for us to create that empathetic space. They remind us to foster relationships. They talk about how this should be a huge part of our priorities. I don't know about you, but I have a hard time keeping my calendar in any kind of manageable state. And so the idea of spending time one-on-one with folks outside of a conference like this is very hard. Yeah, I see people shaking their head like impossible. One leader I know actually in Toronto, best of luck to all of us, keeps his Friday afternoon free every week. And that's where he has his chats, his walks, if he's walking with people, etc. And he creates purposeful and meaningful connection on Friday afternoon. I don't know, I've only accepted that Friday afternoon offer once. It doesn't tend to be the best time, but it's maybe a time that works for him. So we've talked about complexity and the need for emergent work. We've talked about solving the right problems and fostering trust. These things are all very challenging because they require time, something we do not have. The reason people like work plans is that you put the time in up front and then hopefully you benefit from that efficiency later. With emergent priorities, you're constantly planning and doing. It's exhausting. The same with getting to root causes. You frustrate people. You can't stop a room and ask why 5 times, or you can't stop and ask, am I fostering relationship? Do you feel empathy from me? These are not things we would get anything done if we kind of kept that up. So a major criticism of integrated care, social justice, and complexity is it just takes too much time. We're just too behind already on everything, and where on earth am I going to find the opportunity to make this my priority? These problems that we're also solving are critical. Our communities need a solution yesterday. It's not something that, in 10 years, once you open this big, beautiful hub, then that's fine, then that was worth it. People are struggling now. So how do we find this ideal state of changing the systems and implementing change at the same time? It seems impossible. For this, I continue with Frey and Morris, and this is one of their newer books. If you haven't read it, it's pretty awesome. They have a framework for moving quickly while solving deep problems. So Frey and Morris, what they say is they want to give speed a good name. I think our colleague said 90 days, right? That's your speed. That's what you feel comfortable with. They don't give a specific timeline, but I really love the idea of giving speed a good name. I think the matrix that they developed is really interesting because they spend quite a bit of time on the fact that healthcare really loves responsible stewardship. We really love making slow, steady progress. We're not very great at large disruption, that type of thing, right? And really what we're very stressed about is moving fast and breaking things, right? Which is like the Silicon Valley issue that we're not very comfortable with. But what Frey and Morris say is, in fact, we're holding ourselves into responsible stewardship and saying that that's appropriate, whereas we actually should be moving into accelerating excellence, where we're moving fast and fixing things. And if you read the book, they give you a lot of reasons and tips on how to do that. But I would say for us, it's back to trust, right? So it's logic, it's authenticity, and empathy. And I feel like when I am able to create that environment, I can accelerate excellence, and people forgive you, right? It's not that you're doing it right. You are breaking things as you're going, but you're fixing them fast enough, and people have enough faith in you that what you've made a mistake is a genuine one, that you didn't sort of try to do anything difficult or horrible, and you're not like trying to claim credit, or you're not trying to solve something on their behalf. And so it's really important for us to think about how we can be in accelerating excellence. And it's a huge challenge. This is one of my last slides, I think. If you haven't read Hildy Gottlieb, I also love Hildy Gottlieb. This is where we move into the social justice. This is my third framework. Hildy really challenges us to build movements and not organizations. And so this is back to that concept of, what was it, the empire building that you did, Melissa? Yeah, like getting away from us, sort of the ego of it all. But it is hard because our boards also want to see growth. And we were joking yesterday that if you don't merge an organization every year, is your board like, what have you been doing for this past 12 months? But Hildy really focuses on building movements, not organizations. And I've worked closely with my board for them to kind of see this as their responsible stewardship as well, right? We're not here at Flemingdon Health Centre to continue to grow, to continue to take up market share, whatever things that boards think is important. But in fact, we're here to make people healthier. And that doesn't necessarily reflect on a budget or on a P&L, but it's something that you can see in the community. So Hildy, I'll just spend a little bit of time talking about her because I just love her work. She's where I incorporate social justice. And I think social justice is our ultimate end state, and a place that healthcare is not very comfortable with, right? It's kind of feeling like a little too advocacy, a little too rah-rah, maybe not enough kind of corporate and appropriate ways of working. But frankly, we wouldn't need to work so hard on solving complex issues and developing integrated care systems if fundamentally societies were more just. Social justice movements are also some of the most meaningful work with extremely high engagement. And I would say when I am recruiting, writing that horrible briefing note that says why you don't work at Flemingdon Health Centre, I also get to talk about the true, deep, meaningful reasons why you would want to work at Flemingdon Health Centre. And it's about seeing that connection in the community. I think this is a way we can also manage burnout amongst our leadership. If you're connected to a social movement, to a greater cause, to something that feels bigger than all of the individual parts, I think it does really motivate us beyond kind of the day-to-day grind. So Gottlieb shares, the reason social justice is so compelling is because movements define success externally. If a movement is successful, things change for everyone. Whereas organizations, on the other hand, often define success internally by what we accomplish ourselves. Movements also seek sweeping change. Organizations are often satisfied with incremental improvements. And correctly understanding that one entity cannot achieve large-scale change is something that's been really meaningful for us in East Toronto. Leadership of a movement is also distributed and agile. You can really garner a bunch of different leaders in this way in order to connect people. It's less structured, less hierarchical, and really speaks back to that working in complexity and finding those energy flows. Governance of movements is about values, strategy, and direct action, whereas governance of organizations is about regulatory compliance, oversight, and often risk management. So I would argue if you're in a movement, you can talk about risk quite differently, and I find that really freeing because we're kind of spreading things, but we're also having a larger impact. And movements tend to adopt structures and systems that mirror how societies actually progress, and organizations tend to adopt systems that maintain power over others. So shifting in this way can really have a huge and profound effect. By grounding our work in social justice and social movements, we're able to truly achieve community-driven integrated care. At the outset, Melissa shared a couple of the examples of some of the programs that we've developed. I did want to spend more time today about the philosophy because I feel like as leaders, that's maybe a little bit more impactful, and it's probably not us in the room that lead our programs. It's probably other more brilliant people that are on the ground. So I probably won't actually spend time on them, but I'm happy to leave this slide up as we move into questions for us to, if you want me to point to any particular issue or program. I would say, just to summarize about the three ways in which Flemingdon has changed over the last 10 years is embracing complexity theory, working in integrated pathways, and social justice is not new for us, but is something that I think is important for us as a system to start embracing and working towards. So thank you so much. Happy to talk about questions.
That was terrific, Jen. Thank you so much for sharing those insights with us today. And I think also just your energy and enthusiasm. I think it's pretty infectious, actually, for a Friday morning after we've all had some drinks last night. Okay, so why don't we open it up and see if there's any questions for Jen?
Great.
Here,
My rebel razzle table over here.
I'm coming. Here we go.
Love it.
So I want to say thank you. What a wonderful presentation.
Thank you.
Really represents the kind of work that community health centers do.
Thank you.
We're at a table of community health center people here, just in case you were wondering. And I too write that note. It's
scary.
I actually don't write it, but I have recruiters say to me, "Are you trying to talk them out of this
Yes.
job?" And the answer is yes. Because if I can talk them out of this job, they shouldn't be here.
Correct.
And I think that the question that you posed in the beginning is one that I think I would love to have the conversation about, is really about embracing the community health center model and working with our partners in primary health care, which are the health authorities, which are the people that are, because we are not the same. But we are both so needed in the way the world is working right now. And it's how do we do those partnerships? And we very much approach everything the way you do, although you said it so much more eloquently than I can say it. But that system does not work in the system that 80% of the primary care is built on. And that's okay, because it's not required everywhere. But how do we work together to embrace that and say, this is how you work, this is how we work, and there's a need for all of it, including the home care. I'm looking over there, because you said it very well. Why are we trying to put hospital systems into the home? Rather, we should be putting community systems into the home. Well, that's how we were built. We were built about supporting people in their homes. The hospital system was not built to support people in their homes, and the unions that are working in those systems were not built to go into people's homes. So if we continue down this road, we're asking people in their homes to work in the hospital system.
Sure.
Anyway, so thank you for bringing up those points and putting that together.
Yeah, I would also maybe, thanks, Marie-France, I would also say perhaps gently push back that I actually think sometimes when we say community health centers or community-based primary care, or those of us working in social justice and health equity are special and unique, we may actually be missing the opportunity to create that larger integrated care pathway. So Yep. So I would say the last bullet there, the primary care expansions. We've talked a little bit about Jane Philpott and her vision for 100% attachment. In East Toronto, Flemingdon Health Centre is the host, we call it. We're like the host of the funds. We received $9 million between round 0 and round 1. Very technical, but anyway, for 30 partners to attach 21,000. And frankly, a lot of family doctors were not very interested in having an accountability agreement with a CHC. It was an awkward conversation. And the reason why was because these models, right, attract different types of professionals. I think I was talking with a colleague yesterday about like, wow, you're the boss of a doctor. I was like, well, I don't actually say that ever, but technically, yes. And so really what the conversation was is, look at the type of care we can provide. Look at the type of programs that our clients benefit from. It's not that you yourself, Dr. Smith, work for Jen Quinlan. It's that we're working in this integrated system. And that was a nice shift and a nice change. And it was like, and part of an integrated system is accountability. If we're flowing money to you directly as a family health organization or as a team of primary care docs, you are going to have to be accountable for that funds. It's the same as when you're billing OHIP, just in a different way. So we are really trying to kind of think about the primary care networks and the primary care connection to be a big tent approach, to not say like one model's better than the other, which is, I know, not what you were saying, but I think sometimes when I lead with this jargon stuff, right? Like I'm speaking to a group of people I think are interested in this, but yeah, when I lead with a doctor, of course, it's more like, oh, are you aware what a caseworker could do for your returns in terms of, your bottom line? So I've had to challenge myself quite a bit in the last 18 months as the host of some of this funding and working more closely with different physician models and with, physicians themselves are also, I think, kind of eccentric leaders, less predictable. So in my last sort of couple of years of working through some of these complex theories and my riding energy flows, I feel like I'm in a better place to kind of read what's going on and build trust and go from there. But it is, it's messy. So I liked your question, or your comment, but I also wanted to kind of give us the opportunity to say, it's been a long time that community health centers have existed. We're such an amazing model, and yet most people don't know about us. My family and friends don't really know what I do for work, even though I talk about it all the time. And I think that's a problem. So how do we stop that? How do we create our model to be more inclusive and to be spreading rather than kind of keeping it specific? Something to add.
Okay, I got a question there in the back.
Yeah. Jen, a very good presentation. In terms of the government, what do you think the role of government is to play in all of this?
Yep.
And also, how do you roll this in with the OHT work, the Ontario health teams that are happening right
Totally.
now? I love your comments.
Yeah, thank you so much. So for those who aren't aware, Ontario Health Teams are sort of our neighborhood integration entities. I would say I'm an Ontario Health Team's best friend. Ontario Health Teams deeply love to, frankly, take credit for a lot of this excellent work, and I'm happy to let them do so. They're a partner. They're in the integrated care space, right? It's something that I think, again, with that egolessness, with the opportunity to say, everyone is responsible for making this a success. And so, every once in a while when I see a press release without a mention of Flemingdon Health Centre, I maybe send a quick note. But generally, I'm happy for as many people to take credit for this. So I think that would be the first thing, is if people feel invested in your success and if they see themselves in the integrated framework, then they're really excited to brag about the work. So we are Ontario Health Teams. The work that we're doing is part of it, and they get to take as much credit for it as they want. In terms of government, I think it's back to that, trusting primary care and investing in us is a system solution. And I think that's quite new. I I'm not sure if it's going to work. That's my biggest fear, actually, is that when we were talking about this last night, that we're going to attach 100% of Ontarians. Say it's 2029, and miraculously, we've had enough money to attach 100% of Ontarians, but emergency departments are just as busy, and they don't have access to any of their care providers because we didn't invest in teams properly. And then we're all kind of like blamed, like we should have just given that $2 billion to the hospitals because they're just as busy as they were before. So that's my fear. I think if we can collectively maybe work at the system level to mitigate that, because I don't think the government's going to do that. So how can we kind of use this opportunity to say, we're decreasing some of the system pressure? One example of a program is we actually put, oh yeah, cool, I forgot I did those questions. One example is we actually put a stabilizing clinic in a hospital emerge. So our primary care docs with navigators and with community health ambassadors are in Michael Garron Hospital. It's like a community hospital in East Toronto, in an emerge 6 days a week from 11 to 7 p.m. We did the data analysis as to what times CTAS 4 and 5, so the least kind of appropriate use of emerge, was peak. A lot of like young kids with, sniffles or fevers, that kind of thing. And so right now, I will admit to this room that it is not a system savings. They get seen in emerge and they get seen in the access clinic. But the goal is that they then don't go back to emerge. So we're like preventing future times where they would come, and then they're actually stabilized and connected through our 30 partners to ongoing primary care. Hope that helps answer your question.
That was actually the part I was going to ask you to talk about, because
yeah.
I've had the privilege of that. But Jen, thank you. I know you've been so gracious to me. And for those in the room, I am from an Ontario health team. And we were not successful in round one. And I reached out to Jen and hearing that she was. And thank you for your candor, because I think there's so much learning in that space. I'd love to go back to the comments you made around work plans, and your 5 whys were brilliant, by the way.
Thank you.
But when you talk about how we spend time kind of creating time that has not yet happened yet, and then going back to that messy middle, I think your Michael Garron example is an excellent one. And that was the piece you talked to me about several months ago, right?
Yeah.
Is we're so pressured to measure the impacts that actually take time to develop through the messy middle.
Totally.
Is there more that you could say just around this in the primary care space of building courage in teams through pressure from funders where they want results yesterday, but the true results and the true durable attachment that those of us leading this work are actually committed to? It's not a ticky box, we got you a doctor, a nurse practitioner. It's, did you make a long-term and enduring piece? Can you speak a little bit more about that?
Yes, and I'm sure everyone in this room can, because that's one of the wicked questions. I think for me, the messenger is really important. So when I'm trying to plan, or maybe okay, so the messiness, I'm excellent at the messiness. That's like, I feel so good. I feel like, oh, yes, I have 20% of the information I need to make this decision, and I'm just going to make it. And and then if it's the wrong decision, people know that I'm in it, and I'll roll up my sleeves and I'll make a different decision tomorrow. So that's just, I think, like an ethos and a way of working. And I've been in my role for 6 years. I've been in the organization and the community for 10 years. So I think those types of things help. But in terms of demonstrating impact and having some of those tough questions answered or advocated, I think using physician leadership is a critical way to talk to government. All of us in the room are primarily administrators, right? And so we're coming at it from what feels more self-interested, even though I would argue it's not if we're shepherding the system. But for whatever reason, when a clinician brings up the same thing, I feel like government and funders feel that empathy more easily, more readily. So I'm very privileged to work with Dr. Catherine Yu. She's our medical director. She has like 17 different jobs in the health system. And I find when I'm talking to funders or trying to advocate for this longer term impact, it's more impactful when it comes from a clinician leader. And so I would say just practically that's important. And then I think that fear about the tick box will happen, we will attach these people and they won't have access, is the problem that's keeping me up at night. So I don't have a good answer, but I would say, the amount of physician types that we're working with, we just onboarded a walk-in clinic. as part of our model. It took a lot of conversations. They were like, I'm sorry, what? We will have an accountability with you. What does that mean? Da, da, da. But like this high volume walk-in clinic that's very interested in working in a team, so they claim, we'll see, has been a new and exciting opportunity. So I think if we can truly leverage across the different primary care models, we'll have more success as well. And right now, the government is telling us that we can't do that. So none of us got any of these emails, but there was rumors, shall we say, that in PCAT round 2, we won't be able to transfer the funds in the same way to the different types of providers. And so if anyone is friends with Jane Philpott or Sylvia Jones or anything like that, if you could kindly tell them that will really screw everything up, that would be super helpful.
Jen, thoroughly enjoyed your presentation
Thanks,
today,
Andy.
and this whole meeting has been terrific for me. I'm learning and building on what I did know previously about work in the community, and continue to learn in the field. But then I, of course, had the opportunity to sit at the CHC table at dinner last night, which was fantastic. And so I wanted to just build on, and there's going to be a question in here that I don't think is answerable, and I think ultimately this may be a plea to continue the, I thought, excellent debate that we had a little bit last night at table. So it goes like this. So what really resonates to me as a healthcare leader was the references and the prism when you started talking about things like the big tent, creating a movement, and the importance of integrated care, and putting aside focus on really banal outcomes like I put together these 2 budgets and now aren't I a big shot because I have a bigger. I couldn't agree with you more. That is the kind of banality that sometimes absorbs too many of us too often. But we do want to create a movement. We do want to create a movement where there's integrated care and there's better results, and that looks like people having access to care and not being in emergency rooms and all these kind of things. But here's where I think that we do want. I think it's a both and rather than an either or. I do think we want at times hospital in the home, and just as we want community, probably much more community in the home. Of course, for hospital, I look at it through the lens of sincerely believing that as we see things going that used to be 3 weeks in the hospital go to 3 days, and now to no days, you do need to have a sensibility of people, the teams within the hospital, feeling that there's an extension of their embrace or their care into, but at the same time, the best, and people will still have heart attacks, or they will still have strokes, or they will have cancer surgery, but at the same time with a better funded, things like equity. I took that point beautifully from one of the talks yesterday, equity and pay and increasing the snazziness factor of the community team. All of those things resonate hugely. So I'm going to put a plea out that I think the discussion could be framed as more as a both and. So when you sort of express the angst that government will look and say, my goodness, Philpott didn't work, I think that we either win together or lose together. If Philpott doesn't work, I feel right now that we, the broader we, and I feel I'm a part of an OHT. I am part of an OHT. We failed. We failed this really best opportunity. So I guess that's. I'm not sure if there's a question more than a framing of a sort of request to continue. What would it look like if it really we somehow got ourselves to being a highly focused, truly integrated team that comprised, the hospital folks, home care, and community services like Stacy at Sprint and like Vibrant in our OHT region, and of course the primary care hubs, which nurse practitioners and the clinicians, physicians, et cetera, being involved. So not sure if you can catch a question out of that, but
yes, I sure can. Andy, I think I appreciate the spirit and the dialogue. I think that's the whole point. The reason I frame it this way is specifically, in fact, for us to get to that outcome. I think for too long it's been framed maybe not as controversially, let me think. Okay, so I think, yes, the health system, I agree that an integrated care pathway includes acute, includes home care, includes all of it. So when I think of the perfect integrated care program, it does include all of that, but it includes all of that in a way that is more equal. And I think that's a little bit what we talked about last night at the table, is that, when you're in a space and when you're looking at a bundled care budget, or if OHTs end up being in charge of us and then, they have the money and we have to all kind of, politely jostle for it. I would hope that based on these types of conversations and based on this type of experience, that there's more of an openness and more of a willingness to kind of have that tough conversation, that funds don't always have to go to the big player, and that the health system can be improved by connecting the smaller players and by connecting the community players. And that if there's a trust and a willingness to have that be more in the driver's seat, I think the whole system will improve. And I think that there will be an opportunity for clients to get the care that they really want and stay well in the community. And so I would hope that, yes, in 2029, if we all are successful and 100% of folks are attached, but also that, the conversation is different, that it's like, oh yeah, Andy went down to the community health center and saw that there was, a lack of physiotherapists, and that he in fact had 10 physiotherapists in the hospital, but if he kind of moved those into community, that there would be a much broader impact. Like those types of very practical things starting to feel normal, starting to feel easy, I think would be a wonderful outcome for us working differently together. And so I do agree it's a yes and, but I think personally I'm still going to frame it as a little bit of a pushback, a little bit of a like, this is something that is underinvested, less known, because at this point, it feels still like the social justice side, the advocacy side is still what's needed. Because I think right now it's rare that government and funders are as motivated as they are right now. And so I'm very lucky to have people like Dr. Catherine Yu and others helping me push this message forward, but I don't think it's common across the whole province. So if you're in some of the, or the country, if you're in some of the other places where, hospital CEO doesn't pick up the phone, the funder goes golfing with them, and like, that's how you solve the healthcare crisis, we want to keep pushing back against that.
Any final questions? Okay. Well,
Fantastic. Thank you so much,
You're
Jen.
welcome.
Really appreciate this conversation today.